Today, we examine a critical medical case, a right ventricular infarction, a condition often overlooked. Our case involves a 64-year-old man with hypertension and hyperlipidemia who collapses while mowing his lawn. He presents with chest pressure, nausea, and lightheadedness, symptoms demanding immediate attention. Vitals show hypotension at 86/58 millimeters of mercury, a heart rate of 58 beats per minute, and 95% oxygen saturation. Physical findings include distended neck veins, clear lungs, and cool extremities. Initially, the team debated between a massive pulmonary embolism or an inferior myocardial infarction. The ECG confirmed an inferior STEMI with ST elevation in leads 2, 3, and AVF, plus subtle ST elevation in V1 and depression in V2. A resident suggested that if ST elevation in lead 3 is greater than in lead 2 and V1 is elevated, a right ventricular infarction should be suspected. A right-sided ECG V4R revealed clear ST elevation, explaining the patient's hypotension and bradycardia. Skepticism remained, with posterior MI, cardiac tamponade, or pulmonary embolism still considered. A bedside echocardiogram settled the debate, showing a dilated, hypokinetic right ventricle with preserved left ventricular function. This confirmed the diagnosis, a right ventricular infarction caused by a proximal occlusion of the right coronary artery. Key diagnostic clues include inferior MI with hypotension and clear lungs, always prompting a check of right-sided leads. ST elevation in V4 are of at least 1 millimeter is diagnostic, and an echo helps exclude other conditions. Hemodynamically, elevated right atrial pressure with low left ventricular end diastolic pressure is classic for RV infarct physiology. Angiography confirmed a 100% proximal RCA occlusion, with RA pressure at 15 millimeters of mercury and LET at 8 millimeters of mercury. PCI restored blood flow, and the patient's blood pressure improved with cautious fluids and dobutamine. Common pitfalls include nitrates or diuretics worsening shock by reducing preload, and early beta blockers aggravating bradycardia. Management emphasizes preload support with small saline boluses, dobutamine for persistent hypotension, and early reperfusion via PCI. Temporary pacing may be needed for AV block, and beta blockers and nitrates should only be used after stabilization. Within 48 hours, the patient's RV function recovered, and he was discharged on DPT, a statin, and later a low-dose beta blocker. Remember the triad: hypotension, jugular venous distension, and clear lungs should always prompt consideration of RV infarction. The ECG hallmarks are ST elevation in 3 greater than 2, ST elevation in V1, and crucially, ST elevation in V4R. Avoid preload reducers, optimize RV preload, and reperfuse early, as recovery is often complete with timely intervention. When the clinical story doesn't fit a classic left-sided MI, listen to the right heart. Recognizing an RV infarct saves a life.